Yeah, thank you for the invitation, Audrey, and thank you for that introduction. It's good to see everybody. I think I know most people on the Zoom for today. But as Audrey mentioned, we're going to kind of do a little bit of a deeper dive into one of our implementation science frameworks that exists. There's tons of them out there, and this is just one framework. But I am slightly biased in that. I use this framework very often throughout the years of doing implementation science. I think it's a fantastic framework to conceptualize, the implementation process and the context to which implementation occurs. So I'm really excited to talk to you all today about it. Let's see, share my screen. Everybody can see this? I assume, yes, I got some head nods. Okay, so today's seminar is going to go into a deeper dive into the exploration, preparation, implementation, and sustainment framework, or EPIS. So just a quick little overview of where we are going and where we are headed for today. I'm going to quickly define theories, models, and frameworks. For those who are part of the Equitable Implementation Science workshop, this was something that came up in discussion and presentation from Borshika. And so I think it's really important for us to orient ourselves to say where we are when it comes to where this framework sits. Then I'm going to talk about the original design of EPIS and kind of the creators behind it and why it was created. I will discuss the two main components of the framework. There's two kind of core pieces to the EPIS framework that makes it really robust. Talk about measures and measurement of the EPIS constructs, which there are tons of different measures out there that we can use to measure implementation context and process. And then examples of EPIS application. As I mentioned, I've used EPIS in several grant applications, some NIH grant applications that have been funded. And so I'm excited to share some of those applications with you all today. There we go. But before I get into implementation frameworks, I kind of want to orient ourselves again to implementation science. As Audrey mentioned, the learning curve can be steep, and sometimes we want to run off and get into it. But sometimes it's helpful to just take a step back and really conceptualize implementation science in non-scientific language. And so this is an amazing slide or teaching tool created by Jeff Curran, where we think about what implementation science is, what is implementation research, what is effectiveness research, and what are we measuring when it comes to implementation science. And so as we work through this, we know that the intervention, practice, or innovation is the thing. This is the thing that we want to implement. Effectiveness research looks at whether the thing works, right? So when we do our randomized controlled trials, looking at our interventions, we're going to determine whether or not our intervention works for the population and the health outcomes as to which we've specified. Now, implementation research looks at how best to help people and places do the thing, right? So do that intervention. And then implementation strategies are the stuff that we do to try to help people and places do the thing. And then our main implementation outcomes are how much and how well do those individuals do the thing. Okay, so this is really helpful for us to conceptualize, implementation science really in layman's terms in that sense. But what's really important for this teaching tool and for this conversation today that's not specifically discussed here is the importance of context, the importance of external, internal constructs that might influence the implementation process that really get in the way of us doing our implementation strategies, guide how we're actually going to develop our implementation strategies or what we need to do from an implementation effort perspective. And so moving into where we are when it comes to a framework, this was highlighted in the Equitable Implementation Science workshop. This is from the University of Washington, where they kind of try to put things into buckets. Oftentimes, implementation science, so you can sit in a gray area. And so I like to try to orient into, putting things into specific classifications. And so when you look at the different frameworks that exist in implementation science, it kind of boils down to 5 different frameworks or models. So we have process models, and these are used to describe or guide the process of translating research into practice or translating that evidence-based intervention into our practice. Then we have determinant frameworks, classic theories, and implementation theories, where we're trying to understand or explain what influences implementation outcomes. I think a lot of folks here are familiar with determinative frameworks, such as Consolidated Framework for Implementation of Research, where we leverage that as a kind of catch-all attempt of trying to understand what is actually influencing our ability to move an intervention forward as it's being implemented. And then ultimately, we have evaluation frameworks such as REAIM and Proctor's implementation outcomes, where we leverage those frameworks to then evaluate our implementation effort to see how well we implemented and how much did we actually produce from our implementation effort. So going back to that slide of how well did they do it and how much are really our main outcomes when we think of implementation science. So when we take that information, we boil it down into theory, model, and framework. We call them TMFs, right? So what does it mean to be a model? What does it mean to be a theory? And what does it mean to be a framework? So when we think of implementation theory, we have two ideas here. We have classic theory and implementation theory, where we know classic theory is established theories from various disciplines, such as psychology. We know psychology has had a huge influence, not only in implementation science, but also in prevention science. And then also organizational theory that can help understand and explain how implementation occurs. And then implementation theory, these are specifically designed to address implementation processes and outcomes. Now, an implementation model, what we think of as a process model, these describe or guide the translation of research evidence into practice, outlining the specific steps involved in implementing an evidence-based practice or an EBI. And these are suited well for implementation practice, so people actually doing implementation on the ground. It kind of sits outside sometimes of the research landscape. So you have implementation science, you have implementation practice, and you have implementation research. And so this is really well designed for implementation practice and executing real-world implementation. And then you have implementation frameworks, such as determinant frameworks like the CFR, where their focus is understanding or explaining factors that influence our implementation outcomes. And that's where you hear about barriers and facilitators, which I think is very prominent in implementation science and discussed very often, because there's thousands of barriers that get in the way when we're trying to implement just one simplistic intervention that we need to address. And then we have evaluation frameworks, and these assess the effectiveness of our implementation efforts, helping evaluate whether the intended changes have been successfully implemented. And so between the three of these, we know that theory usually implies some type of predictive capacity related to implementation behavior, and it really works to explain the causal mechanisms of implementation. Now, models, on the other hand, are really just used to describe and guide the process of translation, not predict outcomes. And then frameworks are often used to be descriptive. They tend to be atheoretical, and they really just point to factors that might influence implementation, kind of like understanding a scaffolding and putting things into a box to say, this is a barrier, this is a facilitator, this is a mechanism, or at least some type of challenge that we're being faced with that we need to address with an implementation strategy. But neither models nor frameworks specify the mechanisms of change. And this is something that's really, keen in implementation science. Is we're really good on the implementation frameworks. We're really good with implementation models, but we really need to advance our knowledge when it comes to implementation theory and mechanisms of change, especially as it relates to our implementation strategies. Implementation strategies, at the end of the day, are interventions. And for those who have gone through prevention science, have taken intervention development, we know that interventions that are developed based on theory are far superior when it comes to effectiveness than those that are atheoretical or not based on theory. So really advancing that field is important, but we're going to focus most of our time today on EPIS, exploration, preparation, implementation, sustainment, framework, or model. I put that question mark there, and you all can decide whether or not you believe EPIS is a framework or EPIS is a model. So recognizing that implementation science frameworks were largely developed using research from business and medical contexts, the creator of EPIS, Greg Ahrens, who's a professor over at UC San Diego, created a 4-phase implementation model in 2010 to address implementation in public service sector contexts, right? So taking it out of those business and medical contexts and trying to establish an implementation framework for those that work in public sector or in community settings. So the EPIS framework offers a systematic approach to understanding and implementing evidence-based interventions, considering the context as to which implementation is occurring, and also ensuring sustainability throughout the process. So this right here was the original design of the EPIS framework. I know it's very, very small to look into that, but really it boils down to originally what as it was designed was exploration phase, adoption slash preparation phase, active implementation phase, and then sustainment phase. And so there's two main components of EPIS that are discussed and that needs to be taken into consideration. Component one are the phases of implementation. As I said, the E, the P, the I, the S, those are the four phases as to which we think through. And then component two are the contextual factors or levels. And we're going to get into what those exactly are, but at each phase of the implementation process, we know that context and external factors or internal factors to our agency or those that are implementing the intervention, all of these things will actually impede the implementation process or facilitate the implementation process and need to be taken into consideration. And what we see as a barrier that might be experienced in the exploration phase for an organization trying to implement an evidence-based practice might not be true when we move forward into the preparation phase. Now we have these recursive arrows here that you can see, and this really highlights the fact that when we do our implementation process, this is structured in a linear fashion, but we know that implementation does not occur in a linear fashion. And so oftentimes we're learning as we're going and making adjustments to the previous stage and have this kind of optimization loop that gets generated as we move from preparation to implement an evidence-based practice into active implementation. And then when we implement, we're like, oh no, I was not prepared, or I need to have an additional strategy, in my preparation phase to actually make implementation better. And so you can go back to the phases. It's not just you finish preparation phase, you're locked out, you can never go back. And so this recursive action allows us to at least conceptualize and think through, continuous quality improvement strategies to leverage and to really optimize the implementation process. So component one, the implementation phases. So the very first phase of EPIS is what is called exploration. So in the exploration phase, a service system, an organization, a community partner, a county, a state, whatever entity you want to operationalize this as, or other stakeholders, they consider an emerging or existing health need in patients, clients, or communities. And they work actively to identify best practices or evidence-based practices, EBPs, evidence-based interventions, whatever language we want to use in this circumstance, to address those needs of the clients. And then subsequently decides whether or not to adopt the identified evidence-based practice. And so in addition, consideration is given to what might need to be adapted at the system, organization, and individual levels to facilitate the adoption of the evidence-based practice itself. And so oftentimes the exploration phase begins when implementers and relevant stakeholders are aware of a clinical or public health need and are considering ways to address that need. And the implementers move into the next phase of preparation upon deciding to adopt one or more evidence-based practices or innovations. And for those who have worked in implementation science, as soon as I see adoption, an implementation outcome embedded in this framework, you have to think about how this is defined, because each framework, such as REAIM and Proctor's outcomes, might actually define adoption in a different way. So adoption in EPIS is defined as the intention, initial decision, or action to try or employ innovation, evidence-based practice, into an organization. So this is considered uptake at an organizational level. Oftentimes we think about uptake at the patient level, whether or not they receive testing for HIV, whether or not they choose to go on PrEP. But when we think about this from an organizational perspective, adoption is very synonymous when it comes to reach, but for those that are at the organization. So once the organization has now decided that they want to adopt an innovation or evidence-based practice, they can move into what is considered then the preparation phase. And so really the primary objectives of a preparation phase, or at least this phase during the implementation process, is to identify potential barriers and facilitators of implementation. And for those that are, again, more ingrained in implementation science, recognize that identifying barriers and facilitators in and of itself is an implementation strategy. So it's really hard to disentangle, the activities that are proposed in the EPIS framework versus, standard implementation strategies that we know are evidence-based. And, again, you might not have to do this, but it's really important for us to think through the context as to which we're implementing, where we know that there's going to be, snafus or challenges when we're going to implement. But this happens before we actually initiate or actually use the evidence-based intervention within our setting. And so oftentimes we need to assess needs for adaptation to the intervention, to develop a detailed plan to capitalize on implementation facilitators to really turn on those levers within the system and turbocharge them so that we can implement properly. And we really need to address potential barriers. So again, going through this process of identifying barriers and facilitators during the preparation phase can really be helpful when we think of which strategies we should use, how are we going to deploy those strategies, the temporality of those strategies, the dose of those strategies when it comes to addressing or at least preparing our organization to implement an intervention. So we also need to consider during the preparation phase planning of implementation support. So again, those different implementation strategies such as training, coaching, audit, and feedback. So we can think about a package of implementation strategies to use during this phase to facilitate the use of the evidence-based practice in the next two phases, implementation and sustainment. What we know from research, especially when it comes to stages of implementation completion or SIC, we know that the preparation phase, this phase, is extremely important for successful and sustained implementation of an evidence-based intervention. So what you do in this phase will directly predict whether or not that intervention will be implemented with fidelity to the greatest extent that it should be implemented and sustained within your context. But ultimately, for this phase, as you move forward and develop an implementation climate that indicates the use of it, what we do know is that once you go through this preparation phase, then we can move forward into implementing our intervention. So the next phase is implementation. So in the implementation phase, it's guided by the plan implementation supports from the preparation phase. We know that at this phase, or at least what's described in this phase, is that evidence-based practice use is initiated and installed into the system or within the organization. It is also essential that ongoing monitoring of the implementation process is incorporated to assess how implementation is proceeding and adjust implementation strategies to support efforts accordingly. Again, this model, the way it's designed, is to be describing the implementation process of what we should expect when we are implementing an intervention versus identifying or theorizing the hypothetical mechanisms as to which are promoting this movement forward in the implementation process. And then finally, we get to the sustainment phase. And so at this point of the EPIS framework, when we get to sustainment, the outer and the inner context structures, processes, and supports remain ongoing, and that the evidence-based practice continues to be delivered with adaptation as necessary to realize the resulting public health impact of the implemented intervention. And I think, just working with this framework, we need to focus more on sustainment in general. Again, this is not a linear thinking process. As we're preparing to implement our intervention, it would be really helpful to think about how we're going to sustain that intervention during the preparation phase, instead of waiting until, all right, we've been doing this for the year. All right, now we need to figure out how we're going to sustain this intervention in our context. And so again, these are not mutually exclusive phases. You can move in and out of these phases. You can move backward, you can move forward, you can move to one phase and then start back at the beginning of a phase. So that recursive process is really nice as we think about optimization strategies that we can deploy using this framework. So we've actually used this in direct implementation practice. So a lot of folks that are familiar with our work, we are currently leading the statewide expansion efforts in Florida when it comes to SSP implementation or Syringe services programs. This is a longstanding evidence-based intervention for HIV prevention, Hep C prevention, for people who inject drugs, access to sterile injection equipment, access to naloxone for overdose prevention. These are really comprehensive programs that exist, that have been existing, long-standing evidence base, 40 plus years showing their effectiveness, at least in the HIV field. And so for us, we've had this rate limiting step of policies that kind of sit in place in the outer context that have prevented the implementation of this intervention. We know that there's been a public health need. We know the overdose crisis continues to spread throughout our communities. We know that HIV epidemic as well continues in the state of Florida, and so the need for this was always there, but we've had this outer context of these policies in place that made it a third-degree felony to distribute syringes and have possession of syringes. That really was a rate-limiting step when it came to implementation. Now, as we've changed the policy and new policies have come in place, one of the policies that was passed in 2019 allows all counties in Florida to implement this program, but they need to get local approval in their counties. And so at this time, thinking about how we're going to structure implementation and be strategic and being scientific and leverage the best strategies possible to get counties to move across the implementation phase, we leveraged EPIS. And we did this with our community partners, the Florida Harm Reduction Collective, where they renamed EPIS into EPIC for exploration, preparation, implementation, and collaborative sustainability, which I thought was really interesting. And so they call it EPIC. But we leverage the framework to kind of decompose the implementation process. It can feel extremely overwhelming when you're trying to get a county, who's saying, I really want to start a needle exchange program, all the way to a county like Miami, where we've had needle exchange now for 8 years. And so we've learned from that implementation process, but breaking it down into specific phases and addressing each of those phases as we move forward has actually been really helpful when we're thinking about how we're actually doing implementation support in the field. So this is a little bit outdated now, but we currently work with over 40 counties. We do this very brief assessment of the county context when we're trying to figure out which phase they are in the implementation process. And so we can take counties and we can put them into the 4 different phases of EPIS for us to really focus on, all right, this county is in the exploration phase. What strategies do we need to deploy now and focus on deploying to move them from exploration to preparation so they can move forward and actually get an SSP implemented in their context. And so we can actually take those 4 phases and put definitions associated with those phases. So this is where EPIS is really dynamic and can be adapted to your specific project, to your specific context, where you can set guidelines or steps which are taken to move a county, to move an organization from exploration to preparation to implementation and sustainment. So just an example of this, when we think about SSP implementation in our state, a lot of counties sit in this exploration phase because they do not have identified county commission champions that are willing to introduce legislation. They don't have any engagement with law enforcement. Their county has no ordinance that actually is in place to facilitate implementation. And so until we address those issues, until we address those considerations and barriers in the exploration phase, we can't move. We cannot move forward without addressing those issues. And so when we work with counties in that exploration phase, we have a whole menu of different implementation strategies or approaches that we leverage to try to move that context forward. So that is the implementation phases. We have the 4 phases as to which implementation occurs, but then we also have this component of contextual factors. And so this is an updated figure of EPIS. I showed it earlier, the way it was designed in 2018. This was or 2010. This is a new design that came out in 2018 related to a large-scale implementation study called JJ Trials, which I know some folks at were a part of. But again, it took that idea of recursive optimization that exists among these 4 phases and put it in more of a cyclical kind of fashion. But when you look inside of that cycle of exploration, preparation, implementation, and sustainment, you have the outer context, right? So outside of the organization and factors that might influence implementation. We have the inner context. So this is something inside of the organization that we need to focus on or focus our strategy deployment. And then you have these 2 things that kind of sit in the middle and these kind of connections, which it's nice to see, when we think of a determinative framework like CFR, kind of sits in that socio-ecological model and doesn't really explain or help us explain how these contexts are interacting with each other. And so we have something called bridging factors, which are factors that bridge the outer context and the inner context. And these are reciprocal factors, right? So how the inner context is influencing the outer context, and then how the outer context is influencing the inner context. And then we have innovation factors. So these are factors that are specific to the evidence-based intervention itself that might act as a barrier or a facilitator to its implementation. So when we zone in on just the outer context, it describes the environment external to the organization. Again, whatever unit of analysis that you're focused on, the SSP implementation work that we're doing, the unit that we're looking at is the county. So we can leverage this framework to say the county is what we're focused on. So external to the county would be the state environment, right? So that is the state health department, the state agencies, the governor's office. These types of environments as to which the county sits in is what the outer context would actually look like. So this could include the service or policy environment and characteristics of the individuals who are the targets of the evidence-based practice. And so that's going to be the patients and consumers. So in the outer context, EPIS puts the patients in this context versus the inner context, which I think is really interesting. But it seems to be fairly standard as CFR does the same and has its own kind of take to that. We know that the outer context includes inter-organizational relationships between entities, including governments, funders, managed care organizations, professional societies, advocacy groups that influence and make the outer context dynamic. So not only do we have the outer context interacting with our context, but that is a very dynamic context. And it's really hard sometimes to control their outer context. But the outer context can really be profound when it comes to implementation and whether or not we can actually move forward and implement an evidence-based intervention. So within the outer context, EPIS specifies certain constructs. Again, thinking about CFR, our determinant frameworks, where we're looking at barriers and facilitators to implementation. It's kind of the same take that CFR takes. And so you have things like the service environment or policies, and this is like state or federal, political agendas or economic conditions and contexts that actually influence the process of implementation and use of the evidence-based intervention. Again, prime example was the Syringe Services Program policy. That changing that legislation has facilitated not only implementation in Miami, but implementation of 8 programs across the state. So that was really a significant lever in our system to actually drive implementation of that intervention. So when we think about policies, legislation, mandates, funding and contracting, so fiscal support provided by the system in which implementation occurs. This can target multiple levels to support the implementation of the evidence-based intervention. This is something that we deal with on a day-to-day basis when it comes to implementing syringe services programs within counties. We know that there's a mandate under our legislation that states or counties cannot access state dollars or local dollars to actually support the implementation of the SSP. And so that funding component is a very, very significant barrier when it comes to implementing our intervention that we're interested in. But that is something that has threaded as a theme throughout all the years that SSPs have been around. Funding has always been a really tough barrier to address. And so you can think of contracting agreements, grants, organizational level incentives or reimbursement structure. Oftentimes when we're doing like a clinical intervention or implementing a clinical intervention, physicians can be reimbursed for that procedure or for that treatment, which will facilitate implementation. We also have inter-organizational environment and networks, so understanding the relationships of professional organizations through knowledge of the evidence-based intervention. So we're thinking about inter-organizational collaboration, so how well our agency is working with other agencies that are also doing this type of implementation or trying to move this intervention forward and being implemented in their context. And then, as I mentioned, in this outer context, we also have patient and client characteristics. So this is demographics and individual characteristics of the target population or the end users of our evidence-based intervention. And so for a syringe services program, our end user tends to be people who use drugs or people who inject drugs who are going to come and engage with that intervention. So moving from the outer context out here and moving inward into the inner context, this refers to the characteristics within an organization, such as leadership within the organization, organizational structures and resources that exist, internal policies, so policies at the organizational level that might actually, be policies that impede the implementation of an intervention or actually facilitate its implementation, staffing practices or current practices as to which they're doing, and then characteristics of individual adopters. So this might be a clinician or a practitioner, it might be a director of a program, it might be your frontline staff, your case managers, whoever you have in your organization. All of those individuals, if they are going to be using and deploying that intervention that you're interested in implementing, they are recipients of our implementation strategies, and are really key fundamental components when we think about the implementation process and whether or not we can actually successfully implement an intervention. Now, when we look in the inner context, there are several different constructs that EPIS highlights. So we have organizational characteristics such as structures or processes that take place in or exist in organizations that might influence the implementation process. We have leadership, so characteristics or behaviors of individuals involved in the oversight or decision making related to an evidence-based intervention implementation within an organization. This is something when we think of leadership as a really profound implementation barrier, something that we do need to address. We do have leaders in our communities that are really good at implementing and really are, paying attention to the research and paying attention to the newest evidence-based practices and are able to facilitate its implementation very quickly. So identifying those characteristics of leaders that are good implementers versus those that are bad implementers are really important when we think about advancing the science of implementation, but also just moving interventions forward into or new interventions forward into our communities. But when we think about leadership, we think about transformational leadership, implementation leadership. Greg Ahrens and their team, they have the loci intervention that they work on where they actually build leadership skills to actually facilitate better implementation of evidence-based interventions. And so there are specific interventions and strategies that are developed right around just this leadership construct. We also have quality and fidelity monitoring support, which really feels like an implementation strategy at that point in time. They operationalize this as a barrier to implementation or a determinant versus a strategy in and of itself. We have organizational staffing processes, again, so procedures in place when it comes to hiring or review or retention of staff. So something like staff turnover, that is always a really big implementation consideration or a barrier to implementation, and something that you need to take into consideration if your organization does experience high staff turnover and you do implement a new practice. What systems or strategies or supports do you have in place to address that staff turnover barrier? So again, designing policies and procedures at the inner setting level of your organization can really be helpful when you think of how does that relate to sustainability of this intervention in this context. And then ultimately you have individual characteristics. So these are, again, individual characteristics of those that are adopting your evidence-based intervention. So your staff, your leaders, your case managers, and these are characteristics of unique individuals in the organization that actually might influence implementation. So specific staff might have attitudes towards that evidence-based intervention. They might not believe it's an evidence-based intervention. They say, or they think it's too complicated to implement, or they are comfortable doing their current practice, and they don't see the rationale of or the justification as to why they need to do a different type of practice. And so you have things like self-efficacy to gain knowledge or move forward with an intervention that really plays into the implementation process. Finally, we have bridging and innovation factors. And so as we talked about, these are factors or bridging factors are deemed to influence the implementation process as the inner context of organizations is influenced by the outer system in which the organization operates, but those influences are reciprocal. So what we do in the inner context could impact what we do in the outer context. And ultimately, what we do in the outer context or what exists in the outer context will have a direct impact on what we are going to be able to do in our inner context. And so again, thinking about the SSP implementation, the state policy before 2016 was no SSPs allowed. Now we have a pilot program with the legislation, so the outer context changed. New policy came in place. Miami was able to implement a program. 2019, we expanded that policy. All counties can implement. The outer context changed, but still at the county level, we have specific influence when it comes to how that implementation is actually occurring. And when we do move forward and implement, we also have to recognize that what we are doing could actually impact the outer context. So we might be doing something as an organization or as a program that actually might, raise heads, raise eyebrows. Why are we doing this? I don't agree with this. And we might have a reciprocal feedback loop of saying, all right, we need to change the outer context to prevent an organization from doing X type of work or intervention. So bridging factors may include things like interagency collaboration, community academic partnerships. That is something that we engage with often with our community partner, the Florida Harm Reduction Collective. And then we also have innovation factors may include characteristics of the evidence-based intervention itself, how that intervention then fits into our existing system or organization at the different levels. So that's not just at the organizational level, but we need to make sure that providers feel like this is an intervention that they want to be doing. Then we also have to make sure that patients engage and this intervention fits well with the needs of the patients that we see at our organizations. So just some innovation factors, or what are evidence-based intervention factors. We think through who developed the intervention, the characteristics of that intervention, and then the fit of that intervention. So you can see things like the characteristics of the individuals who actually developed or created that intervention itself, and may be subject to support implementation efforts. We have features and qualities of the innovation to be implemented. So this is when we think about determinant frameworks in CFR, complexity of an intervention will directly correlate with whether or not the intervention will be implemented. So we find that interventions that are easier to use will be more likely to be implemented. Those that are lower cost are more likely to be implemented, and those that are lower burden to staff. So again, the characteristics of the intervention itself can actually impede its implementation as well. And then we ultimately have the fit. Again, is there an organizational fit? Is the climate ready for this? Is there structures in place to support its implementation at the organizational level? And then bridging factors. Again, these are factors that thread between the inner and outer context. We have, again, this is just an idea that's described in EPIS. This is not an end-all be-all. These are the only things that we need to pay attention to. And there's a lot of work being done specifically in these bridging factors. But again, community academic partnerships and purveyors or intermediaries. So these are organizations or individuals providing support or consultation for implementation and or training around the evidence-based intervention. So we at the University of Miami, in our work supporting implementation of SSPs in the state, really act as this intermediary where we can kind of thread the needle between the outer context of what the policies say and what the state is thinking and what the state supports and what is happening at the local level. And we can provide guidance back and forth between what we see on the local level and what needs to be addressed at the state, what's happening at the state, and what needs to be addressed at the local level. So we really sit in between these two contexts, and we are able to thread and connect the outer context with the inner context to make sure that the outer context matches as best as we can the inner context to support implementation. So moving into measurement, I'm not going to go into much detail about measurement. You all can find these measures online, and I'll share the EPIS website with you all at the end of this presentation, which is fantastic. They have a website called the EPIS framework. You can go through all these different phases, these definitions, these constructs, and you can actually pull down these measures. But what I want to show is that a lot of work around measurement needs to be done in implementation science. I think as a field, we're moving forward at a probably significant rate at this point in time when we come to measurement development and validity and reliability of our measures of implementation. But you see a lot of focus has been in the outer context with program sustainability assessment tool, which I've used before, leadership competency scale index. Again, in the inner context, implementation leadership scale, implementation climate scale, implementation climate measure, organizational readiness for change. These measures exist when we try to think about how we're going to measure the constructs as to which we're thinking through, but a lot less measures and really no measures on innovation factors really exist when it comes to EPIS. And so there's a lot of work being done on how to better measure implementation bridging factors and innovation factors within this framework. Now, all of this can be really helpful, getting it all together into an implementation strategy development. And so I want to show just one implementation strategy that has come out of EPIS that I think is really, really cool and really fun to work with is the dynamic adaptation process, or DAP. This is an implementation strategy in and of itself. But the way that this functions and how this has been used, this figure comes from the Ahrens et al. Article in 2012, where they were implementing an evidence-based intervention for child maltreatment in California to improve intervention implementation, such as fidelity, provider engagement, improved client satisfaction. But what you can see here are the 4 phases that exist of EPIS, EPIS. And what you see here is this entire wraparound process, or what they call a dynamic adaptation process, where we do assessments of those constructs, right? The outer context, the inner context, the bridging factors that are going to influence the implementation process. So you can see here on the left, right underneath exploration, we have system level assessment, where we're trying to understand the funding, the resources, the policies at play. An organizational level assessment, where we have training space and resources, senior leadership buy-in, team level leadership, culture or climate for the intervention implementation. We also want to do a provider assessment. So looking again at the staff that are at these organizations, when it comes to education or knowledge of the evidence-based practice, their primary discipline, their experience working with the intervention that we're interested in, and their attitudes towards it. And then client characteristics. So again, these are end users of our intervention itself that we want to do an assessment of. Now, all this information is collected and it's used to tailor what implementation strategy will be deployed for that specific setting. What we recognize, and I hope everyone recognizes, is that what works for one organization might not work for another organization, and the level and dose and type of strategy that you use to implement might work for one, but not work for another. And so this idea of tailoring strategies or dynamically adapting the strategies that we're using is a really important concept in implementation science. And so all that information about barriers and facilitators to implementation during the exploration phase are gathered and facilitated to what is considered an implementation resource team. So we have academic researchers in this team, intervention developers, trainers and coaches, administrators, clinicians, and clients, where all that information is fielding in. And what they're spitting out then is, what do we need to do to actually get this implemented in this context? So things can come out such as training, which we know training is an implementation strategy. It is necessary but insufficient to actually get things done. So we have compare with things like coaching or content-driven adaptation. And then we can see how well did that work. So we tailor our strategy, we implement our strategy, we measure that strategy when it comes to our implementation outcomes, such as fidelity, client satisfaction, provider retention, in this instance, completing treatment. And then based on those outcomes, we can then facilitate information back to the implementation resource team to then make further adjustments. Again, that recursive process to say, we've implemented the intervention, we now measured how well our implementation effort was. And if it was successful, great. How do we optimize it? How do we increase reach? How do we increase penetration? How do we get more providers to do what we're doing? Or if it failed, it gives us information on what can we change, what additional strategies do we need, because we're not getting to the outcomes that we've set forward. So we've actually used this dynamic adaptation process at the county level when it comes to SSP implementation. We know every single county in the state is going to have different contextual issues and barriers when it comes to SSP implementation. So again, we've kind of replicated that dynamic adaptation process, as you see here, where we're doing system level assessment, organizational level assessment, staff assessment at these SSPs, and then client characteristics, collecting information from the SSP clients themselves, where we can then have all this information facilitated to our implementation resource team, which is our community partner, different harm reduction consultants, us as academic researchers, and then we can then do specific implementation strategies across the different phases of implementation. Measure those outcomes, so whether or not an SSP policy has been adopted, How are they reaching clients? Do we have equitable reach of those clients? So thinking about equity in this lens, we want to make sure that what we're doing from an implementation perspective is advancing equity. And if it isn't, right, going back to the drawing board and saying, all right, we're not reaching the folks that we need to be reaching with our intervention. What do we need to do? What adjustments do we need to make? What additional resources do we need to dedicate to our implementation effort? So again, this is all just practice. This is implementation practice. We are doing this in real time. This is not implementation research. Then we've also used EPIS to design a research study. So this is a new R1 that was funded a few months ago, where we're looking at a multi-component implementation strategy to increase the adoption and implementation of opt-out testing for HIV and hepatitis C in syringe services programs. So in 2023, CDC endorsed opt-out testing as an evidence-based strategy to increase participant uptake of HIV testing and hep C testing. And so at this point in time, we're thinking about, all right, this is our evidence-based intervention, opt-out testing. How are we going to scale this and implement this across nationwide or across SSPs as a whole? And so this is a cluster RCT with 32 SSPs. We have two kind of components to this. It is access to new funding. So we're actually going to fund organizations to implement opt-out testing. And then we're going to offer a practice facilitation strategy. But I just want to show the temporality component. So this is a specification process that was used according to Byron Powell and colleagues in 2013, talking about implementation strategy specification. But temporality, you see, we've embedded the phases of EPIS into the temporality as to which our strategies are being deployed. So you can see, again, it threads through these three stages. We are only focusing on preparation, implementation, and sustainment. One great thing about EPIS is it's kind of hard to address all four phases all at once. Your project might only address the exploration phase or the preparation phase or just the implementation phase. And so you can kind of pick and choose what phases you want to work with as it relates to the model. But for us, we then threaded that phased approach into how the study was actually going to be conducted, when people entered into the study, how long the preparation phase was going to be, what activities, like from a grantsmanship perspective, we used EPIS to kind of frame what activities we're going to undertake at each phase of the implementation process. So in the preparation phase, these are the things that we're going to do with organizations to get them ready to implement opt-out testing. Then we're going to have a hard implementation date. We're going to then have other strategies that come into play during the implementation phase that were not turned on during the preparation phase, and the same for the sustainment phase. So you can kind of take this phased approach, embed it into your research design, and be very specific about what activities you're going to do during the implementation process. And then those contextual factors that we had, we will be doing contextual assessments across these phases to make sure that we are tailoring our practice facilitation strategy specifically to the needs and the context of the organizations that are in our intervention condition. So taking those constructs, taking those contextual domains, assessing them, understanding where we are when it comes to issues with implementation, designing a better implementation strategy or adapting our implementation strategy to then be deployed within that context. So EPIS framework has a great website where you can search around and look through the different constructs and the different phases that we've talked about today. Greg Ahrens also holds office hours, which is really cool for folks to join to ask questions about EPIS and the application of it. They have publications related to EPIS and how it's been applied in the research setting. And they also have exemplar applications, such as the JJ Trials study. And they also have links to the measures and the contextual constructs that we discussed today. So just some key takeaways. EPIS framework or model, you all decide what you think it is. I think it is a both. I think I'm comfortable saying that it's both a model and a framework. Really provides us guidance on the phases of implementation and the factors that facilitate or impede the implementation of an evidence-based intervention. I view EPIS as flexible, it's dynamic, it can be adapted to different service contexts, such as the public sector, into community, into healthcare settings, and most importantly, not all stages need to be addressed in your application. And then finally, integration of evaluation frameworks to evaluate implementation efforts across these phases is still needed. So we still need to think through regain. We still need to think through proctor's outcomes when we think about what we're measuring or implementation outcomes. EPIS does not provide that. It is not an all-inclusive one-stop shop framework where you're going to get determinative framework plus a process model plus an evaluation framework. And so mix and matching is really, really cool and keen. And I think most people see that in implementation science nowadays, where you use a determinative framework, you match it with an evaluation framework, or you match it with a process model when you're designing your implementation efforts. Just want to thank you all for your time, and I guess I'm going to open the floor to questions.